the cow eye. Don't forget, this is, look in this picture. It's a ball, right? Like, that's why it's called a ball. It's closed. It's your eyeball. Okay? So, it's a whole round thing. So, the tunica fibrosa or the fibrous layer is the one that encloses the whole thing. The anterior part that we see, the clear part of the eye is the cornea. And then the outer part of that ball is called the sclera. Okay, do you see any eyeball there? We have an eyeball that is floating around.
Is it next door?
No, I think chemistry used this lab, so I see Arturo logged onto the computer. That's why it's all cleared out. I don't know where you put just that. Never mind. So, here, and please be sure in the test, you know, I already showed you, we dissected the cow eye, right? If I have a pin sticking on this one, so you identify it as the cornea, the clear part is the cornea, right? The outer whitish fibrous part is the sclera. And you always think about the structures of the eye in terms of what does it do for you. So this one, it's very important. It's the one for refraction, right? 75% of refraction, they say, is accomplished by the cornea. What does that mean? Refraction means bending of the light rays because all the light rays have to be focused in the fovea centralis, the exact center. Okay? So then the sclera is the white. That's what you see when you look at your eye. You see that white, but the white is really out here. It's just that we see it because this is very clear. Okay? You know astigmatism? So astigmatism is because this is not smooth. There may be some roughness over there, and so it affects our vision. Okay? So what's the function of the sclera? It serves as a point of insertion for your extrinsic muscles of the eye, right? And then you have your tunica uvea, the middle layer, which is the pigmented layer. So this one has lots of melanin pigments. So you should know the three parts of the tunica uvea, right? There's the iris, this one right here. This is the iris. This is your ciliary body. And there's the choroid. Okay? And what's the function of the iris? It serves as a control for the amount of light that enters. The opening, you see in the center, there's an opening. That's what you call the pupil. Students always forget the pupil. So right here. So this is what you see. So there's the pupil. The iris is this one, okay? This is your iris over here. And you see that the iris has two sets of muscles, the inner circular and the outer radial muscles. So when this contracts, it constricts, it controls, it makes the pupil smaller, so less light goes in when it's too bright. And then in the dark, these dilator muscles, they contract so that it dilates. So there's more light that will come in, okay? So what's this one? Iris. What's the opening? Pupil. So there's the pupil, okay? There's your iris, the one that gives you the color. Say the color of your eyes is hazel or whatever. And the color is because there's lots of melanin pigments in all of that second layer. And you should always remember why we need those melanin pigments right here, right? The function of the melanin pigments is to absorb stray light, okay? And there is that third part of the tunica uvea, or the middle layer, which you call the ciliary body. This is the ciliary body. Okay? So there was the sclera and there's the choroid. There's the ciliary body and there's your iris. be able to picture, and then there's the tunicum. So this ciliary body is very important. You see, out of the ciliary body, you see this, it's called suspensory ligaments. So that's the point of attachment for your lens. So it keeps your lens right in the center, right? And this is what we replace when we have cataract. So this is the one that hardens as we get old. So normally, this lens is very pliable. So when for short distance, this can become rounder. For far distance, this becomes flatter. But as we get old, it gets hard. So it's not as adaptable. So that's why you say you have to wear reading glasses. Okay? So that's the function of the ciliary body. Okay? Ciliary body. So what are the three parts of the tunica uvea, or the middle part of the eye? You have the iris, the ciliary body, and the choroid. Okay? So the iris controls the amount of light that enters the eye. It is muscle, muscle. The ciliary body is the one that serves as point of attachment or insertion. For what? For your lens. Because why? The lens has to be in the center. It helps me focus, right? And when you get old, you can't focus, but like me, I have to move. So I have to wear reading glasses so I can read, because this is no longer working for me. It's not able to adjust as it used to when I was young. Okay? Then what's the function of this choroid? The choroid contains lots of blood vessels and melanin pigments. So this serves as the blood supply for the innermost retina. Do you follow? There's the retina, the innermost layer of the eye. So you think that the retina should be deeper over here, because the eyeball, right, this is my eyeball. So there's my cornea, there's the light over here, or whatever. So you think that the retina, people would think that the retina is over here, but it's the first part that the light reaches. I was going to say touch, but it has no hands. Okay? So, are you following so far, everybody? This is the blood supply. So look at the retina. Okay? There, here. I want you to, so there is your lens. So there's the ciliary body. And the ciliary body, I told you, suspends the lens in the center. The ciliary body also is the one that makes the fluid over here. In the anterior, you call it aqueous humor. This is the watery. Humor means fluid. We're going to talk about humor also when we study the lymphatic system, Bio 242. Okay? So this one contains the watery fluid called aqueous humor. This one is the jello. Remember the jello? When we opened up the eyes, this is called the vitreous humor. So the vitreous humor is constant. You're born with it. You cannot add to it. You can take away from it. This is the one that constantly is being made by what? By the ciliary body. Okay? So where does the aqueous humor come from? From your own blood. Always, if you have any fluid anywhere in the body, it must have gotten there through your blood. That's the only way, right? Okay? So here there's lots of blood vessels called capillaries that have openings. We're going to study that. And through pressure, it trickles the fluid here. And that's very important. The aqueous humor serves as a site for cleaning. So when you want to, in the springtime, a lot of people, they do power washing for their decks. So this is like power washing for debris over here, and you clean. So it constantly irrigates. Does it make sense, everybody? Again, there is this ciliary body, What does it do? It makes aqueous humor. So the fluid is just constantly flushing. It makes it, but it also drains there. It's called the canal of Schlemm. There's like, let's say there's point A and there's point B. Point B is the canal of Schlemm. You don't need to know. There's like a canal, just no canal. Too many words for you to remember, okay? So point A is the one that makes the aqueous humor, and then it cleans it, and then it drains back to the canal. Go backward. There's circulation. So then you can filter it and clean it. Then you have new aqueous humor. So it has to constantly filter. Does it make sense? It's very important to filter, right? Because you're cleaning. You're doing your spring cleaning there all the time. When you have glaucoma, the glaucoma means there's a blockage in the draining of that aqueous humor. So the aqueous humor cannot leave. So it's there, it builds up. And so one of the symptoms, a very common symptom of glaucoma is burning and headaches. Extreme headaches, and just you feel that your eyes, there's burning in the eye. What do you think? Let me ask you. Look at this picture over here. So I told you, I'm going to use this other picture. Here, okay? There is the yellow part. See, the yellow part is your retina. There's your tunica uvea, the middle, the red part, the middle layer. Okay, so the retina is anterior. So the most anterior, this fleshy part, if you can see this fleshy part over here, that's my retina. Okay? Then the middle red part is my tunica uvea, what we just talked about, the choroid, the ciliary body, and the iris. Okay? So the retina is just only nerves. It's only nerves, there's nothing else. It's just a bunch of nerves. And if you remember, I told you nerves have no food supply of its own. Right? It doesn't store its own food supply. Do you remember? It relies on a fresh supply of glucose all the time. Do you remember that? Right? Muscle stores glucose. Your liver stores glucose, but nerves, they don't store glucose. So where do they get their glucose? From the blood, right? That's where it's being delivered. So where is the blood supply? Right here from the choroid, the second layer. Are you following? Right? Because the outermost layer, that's just fibrous. It's for protection of the eye, which sits on your orbit. Okay? So it serves as shock absorber cushion. It's the middle layer which contains the blood vessels that will nourish my innermost retina. You follow? Okay? Look, so which means that the retina should constantly be touching the blood supply. That is the function of this aqueous humor. The fluid there, make sure that the shape, or there's enough fluid there, or enough pressure there to make sure that the retina is constantly touching my choroid. You follow? So, look, if there is not enough fluid here in your aqueous humor, right, like the balloon, if there's not enough air, it shrinks like a raisin, right? So, if it shrinks, it's not going to be able to touch this choroid. No blood. So, what will happen to my neurons? Won't they die? Right? They will die. So, that's also, now, do you understand why, let's say people with diabetes, they can go blind, because with diabetics it's a different problem. With diabetics, the sugar they must have, even though they have lots of sugar, the sugar is not able to go into the cell. So one of the cells is neurons. It doesn't go inside, they can go blind. But let's talk about two conditions. One is glaucoma and the other one is retinal detachment. Okay, glaucoma and retinal detachment. So, will you go blind in both conditions? I mean, is it possible to become blind with this? What do you know what retinal detachment means?
The retina comes loose from the back.
Correct. Detached, right? It becomes detached. So that can happen with extreme force, right? So it can detach. So that's why when you do sports, they really don't like it if you hit the face. There's a danger of that being detached from extreme pressure. So when it detaches, just imagine, look at, when this retina detaches, no more blood supply. You will go blind, right? How can you go blind with glaucoma? Look at this. So when you have glaucoma, remember, the drainage of the aqueous humor is being blocked. In the meantime, you keep making or adding and adding to the fluid. It's just the drainage that's being blocked. So look what will happen. Won't you increase the pressure in the eyeball? It's a closed ball. So what will happen? Aren't you going to push this retina flat against the blood supply? When you flatten that, that's not going to do its job, right? Remember, cells rely on their shape to be able to do its job. So if you change the shape of the neurons, besides they have to have that shape, right? And then that axon like that. So if you make a kinkiness in there or you flat, it won't be able to do its job. So you will become blind also.
It's a silly question, but if it's just a matter of the blockage, why can't they go in and put a stent in?
They put a stent. Oh, that's a good silly question. Very, very good. I don't know.
I mean, it would seem
How
simple.
big? But the stent, how big will the stent be? I don't know.
I mean, it depends, I guess, where is the blockage? Is it just right there at the eye?
So, yes. Yeah, right.
I mean, you would
at
think
the
they
eye.
would be able to just go in
What they
and
do-
drill it out, or, you know.
I don't know. I don't know ophthalmology. All I know is they put eye drops that, first of all, number one, will decrease the pressure. And then number two, they apply directly there something that thins out the blockage. So some form of thinner that will thin out the blockage, and so that then it will start draining again. But as far as stent, that's a good question. I don't know. Sometimes the reason we put a stent is because there is hardening, like in the heart, right? There's a hardening, and so even if you clear out the blockage there, if this is already hardened, there's a roughness.
It's gonna block again.
It will happen again. So maybe the pathology or the, anatomically, it's different. I don't know. But I know that the stent is big. In the heart, it's big. Here,
It would have to be
it has to
really.
be microscopic, so I don't know. But will you be blind on both?
Yep.
Yes. Which one is more dangerous, do you think?
The retinal.
Yes, very good. The detachment, right? Because how can you solve that? It's been detached already. So that's why it's a danger. When you encounter someone with retinal detachment, it's an emergency. They send the patient immediately for surgical correction. Okay?
Can they reattach it?
Yes. Yeah.
Maybe.
But time is their enemy, right? You have to do it very quickly because nerves are very precious, and besides, they don't regenerate, right? They don't have centrioles. Okay, so we just talked about the lens, and we said that the lens is very important for being able to read. So for your test, you need to know this, right? Refraction. You need to know these terms: emmetropic eye, myopic eye, and hyperopic eye. Emmetropia, myopia, hyperopia. Another form of hyperopia is presbyopia. So this is your normal eye. Look at what needs to be done. It's very important to channel all those light waves to the exact center. This is called the fovea centralis, because that's where your cones are. So you want to really be able to see sharply. If your light waves are not channeled there and they're spread apart, you won't see clearly. Like with people with cataracts, maybe they see, but it's very hazy. They don't see sharply. When my mother had her cataracts replaced, and she was jumping up and down because she didn't realize it's for many years that she couldn't, she just thought she needed glasses, that's all. She couldn't really see, but now she can see clearly again, okay? So with myopia, look at what happens this is called nearsighted. So the light waves, so it's either you have a long eyeball, right? Or your lens is too round, so that the light waves are bent and they meet even before touching the retina. So how do you solve the problem? You have to bring the whatever book closer to you. That's why you say you are nearsighted, so that the light waves can reach the retina. So how do you correct this? You correct this with a concave lens or diverging lens, right? So look, you diverge the light waves so that they can converge right there at the center. So a concave lens is a diverging lens, okay? People with hyperopia or presbyopia, they're the same. So people who have these conditions, just like presbyopia is what? It's hyperopia of old age. So as you get old, just like me, I'm wearing reading glasses. That's what you call reading glasses, okay? So what happens? Look, the lens is no longer as bendable as it used to be. Or you can also have this when you're young if your eyeball is just it's just very round or short. Okay, so that the light waves, they converge beyond the retina. You can't see. You have to move the book far so you can really read it properly. So how do you correct that? You correct it with a convex or converging lens. So you want the light waves to converge and they can meet right there at the retina. So your test will have this, and I will ask you identify which one is emmetropic, hyperopic, presbyopic, myopic, and then I also ask how do you correct, because this is always common in your practice. Again, this will come out in your test, okay? And in your test also, the picture of the tongue will come out. I ask you to give me the three cranial nerves that is important for taste, and use an arrow to show their area of coverage. So 7, 9, and 10. 7 is the anterior part of the tongue, right? Anterior 2/3 of the tongue is monitored by cranial nerve number 7. 9 is the last 1/3, and 10 is everything else right there. Then they go to what? The parietal lobe, okay? And then for smell, I have a picture of the nose. You show me where it is. In the olfactory epithelium right there, by the ethmoid bone, right? That's where your olfactory epithelium is, and it goes to cranial nerve number 1 to what lobe? The temporal lobe. And then also, don't forget the collaterals to your limbic lobe, right? That's why it brings back memories and emotions. And then for the eyes, I have this picture, and you'll be able to tell me and how do you correct. I also ask about glaucoma and retinal detachment. I ask about that, and I ask which of the two is more dangerous and why. Okay? This is a good review for your lab exam also. Okay? Next. Now that we have talked about that, let's see how we see the physiology of vision. So, Refraction is just bending the light waves right here. Now, once we bend the light waves, I want to know how does the retina make me see. Okay? And so, look at this is your eyeball. There's your eyeball. And then they just cut a small portion of the retina to show you a magnified view of what the retina is made of. First of all, right here, I'll use this one. So again, a small portion right here, and there is your retina, right? There is your retina. Remember that the retina is sitting on your tunica uvea, so there's your choroid on top here, right? And then there's your sclera. So there's my choroid, and then there's my sclera. So that's why the retina relies on the choroid for blood supply. Look at the composition of the retina. It's just a bunch of nerves. It's just layers upon layers of nerves. So the pathway of light, like this, right? The light enters that way. Okay? Here, in this physiology of vision, you will understand, really appreciate the word specificity. Just like then the receptors are very specific. It's the same here. Okay? Look at this one. So, first of all, I want to look at what the retina is made of. It's all nerves. Then there is this epithelium over here. So it's the epithelium that is sitting closest to the choroid. Are you able to picture that? So there's my eyeball. There is the eyeball, you see, right? So the retina is made up of a bunch of neurons sitting on a layer of epithelium. Okay? That epithelium is called pigment epithelium. So what do you think? What does pigment epithelium contain? Pigment. Melanin. What's the function of melanin? Doesn't it absorb stray light? It's very important. All stray light should be absorbed because it's going to affect our vision. We won't be able to see clearly. So any extra light waves absorbed by my choroid, absorbed still by my pigment epithelium. So only enough light rays, just what you need to be able to see. That's what's going to enter my nerve pathway. Okay? Number one. Number two, the pigment epithelium, very important. It contains vitamin. What's the vitamin for vision? A. Vitamin A right here. Retinol, which is different from retinol, retinoic. So there are three forms of vitamin A. You're not gonna, in nutrition, I teach that. Retinol, retinoic acid. The one for vision is called retinol. And actually, vitamin A is the key to be able to see. That's why if we are deficient in vitamin A, we become blind, right? You call it night blindness, but you really are blind even during the day. But you will see why. Okay, before we move, we'll talk about night blindness versus daytime blindness. But vitamin A deficiency produces blindness, period. They just say night blindness because it's more pronounced at night. And I'm going to tell you why. So, your eyeball, so you see these receptors. Receptors are the ones that receive the sensation, right? Right? They're the ones like thermoreceptors, baroreceptors, nociceptors. So look at, that's why I told you, it's in this physiology of vision, you will appreciate specificity. Look at this one, the pathway of light. Do you see that? It's going that way. And it's passing through these neurons already. Ganglion, bipolar, amacrine, horizontal. And yet, these neurons right here, they do not respond. to the stimulus specificity. Only the receptor right here in the deeper layer, as the light enters, it will bypass through these neurons. It will only stimulate this one. What do you call them? Receptors, photoreceptors. And you have two groups of photoreceptors, the rods and the cones. I know you know that. So there they are, you see. They're just named according to their shape. One looks like a rod, the other one looks like a cone. But look at this, very important. Oh, yes, very important for you to know. The cones are cones for concentrate. They're concentrated right here in the exact center, in the fovea centralis. So you only have, what does your book say? How many millions of cones do you have? About 20 million cones, and then about 100 million rods, right? So even though the rods outnumber the cones are concentrated in that exact center over here. They are the ones responsible for sharp vision, right? Color vision, the cones, and for acuity, visual acuity. The rods, isn't that for dark vision? The rods are spread all over. So, does it make sense? When you have vitamin A deficiency, the deficiency of vitamin A will affect both the rods and the cones. But because the cones are all concentrated, you can still see because they're all packed together. But the rods are spread apart. And the rods are for night vision. So, night blindness is the first symptom of vitamin A deficiency. Why is vitamin A so important? Look at this picture, okay? These rods and the cones, I want to look at what they have inside. Look at what they have inside, okay? Look, the composition of the rods and the cones. You see, retinal. They contain the vitamin A. So that's why, I know you see this part right here. You see, remember the pigment epithelium? I'm going to go there. Look at the pigment epithelium over here. You see? So, the pigment epithelium gets vitamin A, right? It contains that. And it transfers the vitamin A. So, all your photoreceptors, the rods and the cones, should contain vitamin A. That's why we always have to make sure we have extra stored in here. Do you follow? In fact, they say our pigment epithelium always make sure that you have enough for 4 months supply. So you can be deficient in vitamin A for up to 4 months, you can still see. After 4 months, then you start having vision problems because it is so important to vision. Why? That vitamin A over here is going to be delivered here. It is the vitamin A that makes you see, period. Why? Look at what happens. Look, the vitamin A inside here, when the light waves hit the receptors, this is the receptor, right? The rods and the cones, that light waves, what the light waves do, they change. See, photon, the light waves. They change the shape of the vitamin A. So when you change the shape of the vitamin A, that triggers the generation of action potential. Do you follow? And so then what happens is the light becomes converted to a nerve impulse at the photoreceptor layer. Then from there, that nerve impulse is going to be relayed to the next neuron, until you see this picture over here. No, this one. You see? So I hit, the light waves hit this one, right? The photoreceptor layer. It hit this one, and what did it do? The photoreceptor, because of the vitamin A, it was able then to convert the light stimulus to a nerve impulse. So from here, synapse with this next layer, which is my bipolar neurons, the bipolar synapse with my ganglion. And the axons of the ganglion, then, they converge and leave the eyeball to become your optic nerve. Where is it going to go? To my occipital lobe. So then, I am able to interpret that as something that I see. Do you follow? Everybody, what you think? Again, there's my light stimulus, right? Because of specificity, it will just bypass all these neurons because they don't respond to that one, right? They do not have gates that will open to photon stimulus or light waves. It is the rods and the cones. Specifically, what the vitamin A in there. When they change from cis to trans, you don't need to know that, but the changing of the shape of the vitamin A is the one that generates action potential here. So it is now converted from light wave to nerve impulse. Then your receptors will synapse with bipolar, bipolar synapse with ganglion. The ganglion axons are the ones that we saw in the eyeball. Remember, I flipped it. There was a stump right there. I said, this is your optic nerve. What's the composition of the optic nerve? All the axons of this ganglion. So, see? Nerve impulses propagate along optic nerve. It becomes the optic nerve that we saw in the posterior or at the base of the eyeball. Do you follow? Okay? So, look, this is very important for us to appreciate. You have about 120 million rods and cones. A lot of them. By the time it comes down to numbering of your ganglion cells, you only have 1 million ganglion cells. See how they converge all that stimulus? So that there is the action potential. You can even think of it as being enriched from many, then you just harvest it into just hundreds of millions to just 1 million ganglion. So the amount of information that's entering your brain makes it really very detailed and sharp. Do you follow? There are these other neurons here, the horizontal cell and the amacrine cell. You see that? They have nothing to do with the direct pathway. All this does is to just adjust the contrast. Like when I was young, I remember I had 2 older brothers. I was scared of them. They're boys, right? So when we watched TV, it was always my job to get up and switch the channel or adjust that contrast. But now it's all just HD, everything, right? But that's what these do. The horizontal and the amacrine cell. They just do the contrast, make sure that if there's anything unnecessary to your view of the vision, they take care of that. Do you follow? Now we see, so you see, look at this part right here. When you do ophthalmology, and you're going to do that over there, I have some, what do you call this, ophthalmoscopes and otoscopes. If we have time, I'm going to ask you to look into the eyeball. When you look into the eye of every individual, you focus and you will see there's an area of just brightness. That part right there is called the blind spot. You really are blind there. It's blind because, look, this is the point of exit of my axons of my ganglion neurons. I don't see receptors there, so I don't see in that spot. That's the point of exit of my optic nerve actually. Okay, that's why it's called blind. So one more time, how do we see? First, the light waves pass through the cornea. You bend the light waves. Then lens, bending the light waves further. To focus the light waves right there at the center called centralis, fovea centralis. And then in the center, what happens? The light waves will synapse or activate the receptors right here, the receptors, the rods and the cones. So the light waves will be converted to nerve stimulus at the rods and cones layer. So from here, the rods and the cones synapse with my bipolar neurons, bipolar in shape, that's why you call it bipolar, right? And then bipolar neurons. So it goes like this and then goes like that, right? So bipolar synapse with ganglion, and then the axons of the ganglion becomes my optic nerve. Okay? So I want to trace this optic nerve. I know the optic nerve is going to go to what lobe of the brain?
Occipital.
Occipital lobe. Very good. But let's trace the pathway. And this is also going to come out in your test. This picture. So I will ask you, you don't need to be very technical with me. It's better to just write what you see. So here, this is, so there's my light waves, right? And the optic nerve, look at, first of all, optic is what? Sensory, motor, or mixed? It's only sensory. Very good. So will this one have motor neurons? No. It's just ascending pathway, no descending. So if there's an injury here, will you be able to move your eyeball? Yes, it has no motor function, just sensory, you can see. Okay? So here you go. Look at the optic nerve. The optic nerve consists of two groups of fibers. One, I'll say the temporal, right? This is the So first of all, your eyeball, there's two sides to the eyeball, right? This is, let's say, the nasal side, right? And the temporal side on the other side, right? So look, this is also nasal side and this is temporal side. So this part makes me see over here, right? And the nasal fibers is the one that makes me see over there. You see that? But there is, when they enter my brain, as they enter, you saw this, they cross over to the other side. There is a part here called the optic chiasm. So the nasal fibers cross over to the other side, you see? And the temporal fibers, or the lateral fibers, whatever you want to call it, they stay on the same side. So in your test, I have a picture like this, and I ask the student to use arrows to show me where is the optic nerve, the optic chiasm. So this, all of this is the optic nerve, the whole thing. This is all optic nerve. Then when they cross over, this one is called optic chiasm. So after the optic chiasm, you now call this optic tract. And it goes to your thalamus, and from there, it radiates, optic radiations. It radiates to your occipital lobe. So, optic nerve, optic chiasm, optic tract, then from the tract, radiate to your occipital lobe. So I have a picture like this, and I ask you, label, where's the optic nerve, optic tract, optic chiasm, optic radiations. Then I say, predict what will happen if there was a transverse cut on the following. Let's say on the optic nerve. So if there's a transverse cut right here, what do you think will happen?
You're going to be blind in that eye.
Yes, blind on the right eye. That's all I want you to write down. Then I ask, if there is a cut this way, what will happen?
I'm blind in both eyes.
Both eyes completely blind. That's all. So, how about if there was a cut this way? Where will you be blind?
The inner.
Correct. That's it. Some people, they just, on the, just right. I won't be able to see the fibers from the inner side, or the nasal fibers from both eyes will be cut. You see? You cut. So, I won't be able to see from the nasal side of both eyes. Right? You see that? That's all I want you to write down. How about if I cut this way? If this is the one that's cut, I won't be able to see on the lateral side of the left, right? Because that's the one that's cut. And the nasal side of the right. Right? So, that's all. You should just, the one thing that's very, how about if there's a stroke here? I'm blind, right? I can't interpret what I see. I'm blind, you trace again, I'm blind there and here. Okay? That's all. But the thing that's very important for you guys to remember, it's very easy to answer that part. The only way you'll make a mistake is if you forget that the nasal fibers cross over, whereas the lateral fibers stay right here. That's what you need to remember. If you cut anywhere, as long as you remember that, okay, remember this picture. The middle is the one that will cross over to the other occipital lobe, and the lateral fibers are the ones that go to your same side occipital lobe. So it's the same for here, you see. Okay? So if you know that, you can answer that section. Remember which crosses over. So again, this picture going to come out. You label, where's the optic nerve, optic tract, optic chiasm, and then plus you tell me, predict what will happen. What else is going to come out? The refraction abnormalities. Presbyopia, emmetropia, myopia, plus glaucoma, retinal detachment, that's going to come out. Okay? Vitamin A deficiency. I used to ask, does vitamin A deficiency only affect night vision? No, right? But now you can explain why normally it exhibits as what do you call this? As night blindness, because of the way your photoreceptors are spread apart. The rods spread apart and the cones just concentrated. And what's the blind spot? Blind. It's blind, really. You don't see. Because what's absent? Photoreceptors. No photoreceptors there. Okay? So, the next is your ear. And this is the last part of Bio 241. Okay, break for 5 minutes, then we finish the